I would like to invite Dr. Ajith Dissanayake to convey the message of a structured approach to the poison child clinical decision making from door to deposition.
Good morning, all of you. I am really appreciated and honored to address you all. Actually, I must thank Professor Priyani, Dean of Faculty of Indigenous Medicine, and your hospitality and welcome, and as well as my friend Professor Kavinda and Dr. Leera Singh and Dr. Mara Singh, who work together as a family to fulfill this small workshop. Actually, that it is a trending topic, that poisoning. Poisoning is just like iceberg phenomena. This is a vast field, especially in pediatric. Most of the cases are actually that not known because of surveillance are very poor. The awareness must be there. As a medical officers, we have to convey our messages to the community. Today my topic is structured approach to the poison child. The clinical decision making to go to the disposition. Actually, that this is the way of doing when the child come with the suspected poison. What are the things we have to do in nutshells? My objectives is apply to the ABCD, that means initial assessment and initial management of the poison child, as well as the focusing of history and targeted examination of the poison child, as well as recognize the toxic norm. That means following the toxin, that poison, there are different type of symptoms and signs. With that, we have to identify the poison which not known. These are the toxidome. We have to get a bit idea about that. Other than that, management principles, we have to just touch. The basic toxicology exposure, actually that substance, the toxicology substance enter the body, it might result in illness or injury or organ dysfunctions. මොනහරි විසක් ඇතුළු වුණාට පස්සේ ඇඟේ එන වෙනස්කම් මොනවද කියලා අපි දල අදහසක් ගන්න එක ගොඩක් වැදගත් වෙනවා. The toxic substances for the child especially can be entered by the injections and inhalation, as well as the dermal touch up. That means ඇඟේ මොනවා හරි විසක් ගෑවුනහම එන්න පුළුවන්. ඒ වගේම in adults, in IV injection, that sometimes compared to the children, difficult, that most of the adults only get IV injections, like some addictive, that heroin and all things, that some heroin addicts. Other than that, what are the very important in children? They are curious. That means try to explore everything that they have explored. දැන් හැම දෙයක්ම හොයන්න බලනවා. එතකොට එයාලා accidentally get caught with poisons, as well as hand to mouth reflection. අතන අහුවෙච්ච එකක් හැම වෙලාවෙම කටේ දාන්න බලනවා. They are not relying that. Always they don't know what the danger of the poisons and anything. Just like some people in adults life. Yeah, pediatric poisoning. Actually, that as snakebite, Professor Kavinda told, it's a major public health issue in the world. Estimated 45,000 children and adolescents are poisons in 2018 WHO report says. and 60 out of 1 lakh annually pediatric poisoning in Sri Lanka. The age 1 to 12 years. The highest in below 5 years. They are not known much and there's a toddler's life. Most of the poisoning incidences are accidental. As I mentioned earlier, that epidemiology of study that around 5 years, they are more susceptible for getting poisons and toxic. And geographical variations, the income countries, very higher, richer countries are more in drug poisoning in children because of they are more vulnerable to taking accidentally drugs, some pharmaceuticals. In low and middle income countries, just like in our country and Indians, they are susceptible to kerosene oil poisoning and pesticides and other household poisoning and corrosive poisonings. Most of the poisonings in children's outcome is good, actually very mild incidences, and rarely severe toxicity agent with organophosphate and hydrocarbon, that means kerosenes and opioids also there. The seasonal variation, as well known, the school holidays are more frequently admitted with poisoning. Other than that, as I mentioned earlier, the surveillance, that awareness of the society and data is very less in most of the countries. What are the incidences? Why is the children? I mean, ළමයි ගොඩක් poison වෙන්නේ කියලා අපි වැළුවොත් එහෙම මෙයාලගේ curiosity කොහොම බලන්න යනවා වැඩි ළමයි හැමදාම. අනිත් දේ තමයි the supposing we are thinking that only one tablet is not a poison, like no. According to body weight, it is a high toxics. We have to think about that. According to the body weight, it's a major consequences of it's less amount of poisoning compared to the adults. Other than that, detoxification and all things are their organs are developed, not much developed. Then toxicity getting higher because of developing organs are there in children. Other than that, the danger, they don't know the danger of the poison. That means inability to treat and identify the poisons. Other than that, most of the parents, not the most of the parents are trust about their caregivers. They are not looking after children. So they always the victim of getting poisoned. They are exploring actually that find easily the poisons. And other than that, rapidly developing the symptoms of children compared to adults. The acute management of the poison. Actually, initial stage, the resuscitation. And other than risk assessment as well as a remediation. That means improve the situation. Actually, that resuscitation, we don't want to find what are the poison. You have to manage as a immediate ABC. That means initial resuscitation must without finding the cause for the poison. The ARV, actually that most of the ARV and Glasgow scales, we have to find out they are a patent, and if it is below 8 GCS, we have to intubate. And breathing and respiratory depression, we have to identify that most of the opioid and salicylate getting breathing difficulties and getting metabolic acidosis for the mainly in salicylate than other most of the poisons. That's circulation. That means we have to restore the circulation and disability. They'll find out they are going of deteriorate the conscious level and hypoglycemic, as well as they are going the management and deteriorating. We have to explore, and other than that, find out the and decontaminates as much as possible. Mainly, history is most important because of the amount of poison. That means we have to get the idea of the concentration. What is the product we have to find out, and quantity, that means amount, we have to calculate quantity and product, as well as the weight of the child is very important, and the route of the injection, that means inhalation or injection or skin contacts, very important, and the time, because of the depending on the time we have decontaminations, and a management plan might be vary. Yeah, actually that we have to find out the toxidome. That means after the poison, උනාට පස්සේ මොනවද ඇති වෙන්න පුළුවන් සංකූලතා. ඒ කියන්නේ එයාගේ රෝග ලක්ෂණ සහ අපි එක්සැමින් කරාට පස්සේ මොනවද දකින්න පුළුවන් වෙනස්කම් වලින් අපිට දල අදහසක් ගන්න පුළුවන් ඒ මොනවාද ඒජන්ට් එක සම්බන්ධ. So there are different toxidome. Most of the are the big four toxidome, as we mentioned: cholinergic, anticholinergic, and opioidic, and sympathomimetics. Those are the toxidome we have to consider mainly. I will come each one by one. Anticholinergic toxidome. Atropine poisoning, tricyclic depression, antipsychotic drugs වලින් එන්න පුළුවන් anticholinergic toxidome. That means they present with tachycardia, hypertension, උඩටම හුස්ම ගන්නවා වැඩි, ප්‍රෙෂර් වැඩි වෙනවා, ඒ වගේම උෂ්ණත්වය ගොඩක් වැඩි වෙනවා. Mad as a hatter and red as a beet, dry as a bone, blind as a bat, and hot as a cat. That means මෙයාලගේ විශේෂයෙන්ම දකින්න පුළුවන් තමයි dilated pupil. Pupil එක dilate වෙලා තියෙනවා. ඒ වගේම dry skin. මේන්ලිම features තමයි මේ atropine poisoning. අපි ගොඩක් වෙලාවට ඉස්සරහට කතා කරන්න වෙනවා. OP poisoning වලදී අපි atropine දෙනවා. atropine toxicity එක එනකම්ම සමහර අවස්ථාවලදී දෙන්න වෙනවා atropine. එතකොට මේ අපි දැනගන්නේ patient saturated atropinized වෙලාද කියලා කියන්නේ මේ anticholinergic toxidome එකක් විදිහට present වෙනකොට තමයි. ඊළඟ cholinergic toxidome ඒකෙන්න පුළුවන් organophosphate. පලිබෝධනාශක නාශක වලින් organophosphate, carbamate, ඒ වගේම මෂ්රූම් හතු වර්ග වලිනුත් එන්න පුළුවන්. මේක වෙන්නේ acetylcholine choline level එක ගොඩක් වැඩි වෙනවා. Its main features are bradycardia. and tachypnea, and very difficult to breathe in bronchiolinia. මේ patient ලගේ විශේෂය තමයි pinpoint pupil එකක් එන්නේ. OP positioning එකක් ආවම especially bradycardia and pinpoint pupil, we have to think about some OP positioning. Organised toxicology එක ලක්ෂණ mainly ඒ වගේ තමයි bradycardia, pinpoint pupil එනවා නම් අපි හිතන්න වෙනවා any clues of poisoning, the cholingic toxicology. Sympathomimetic toxicology, cocaine, amphetamine and methamphetamine. Ice, you know much about that. Ice are coming with dilated pupils and severe sweating and agitation and tremors that are very irritable. Most of the people will know with confused with anticholinergic, but patient is leaking. That leaking is very sweating. And other than that, opioid toxicology. ඒක වෙන්න පුළුවන් heroin poisoning වලින්. ඔය morphine, methadone ඒ වගේ ඒවා වෙන්න පුළුවන්. Mainly with bradycardia, hypertension, as well as same scenario that they also present with pinpoint pupils, coma and altered and hyperreflexia. That නිකන් පණ නැහැ වගේ ඉන්නේ ගොඩක් වෙලාවට. You have heard and known about the heroin poisoning. The sedative toxicology, that means some diazepam and alcohol. You have no much drunken people, just like this presented with this type of toxicology. For the sake of completeness, there's a serotonin syndrome. That means some antidepressants and opioid and some antibiotics also presented with agitation and anxiety and confusion. This is serotonin toxicology. It is also one part of poisoning presenting in this way. We have to get a rough idea about the toxicology. Just after the admission, we have to think. Then after that, we have to come to the investigation. ECG, we have to take that unconscious, so some agitation we have to rule out. Some antidepressants, QT prolongations. You have to see the QT prolongation here. This is a normal, this is prolongation. And blood gas we have to take because of the some metabolic acidosis, have to rule out. And specific level of paracetamol, and is not for the doing in Sri Lanka, and digoxin and all the other have to rule out because of for the developed countries, they are doing those type of investigation frequently. The ECG changes, antidepressant QT prolongations, and QRS widening in carbamazepine and tricyclic antidepressants. Bradycardia, the beta blockers and calcium channel blockers, digoxin, just like most of the drugs cause bradycardia. And tachycardia simple, that means methamphetamine, amphetamine, anticholinergics, that means as atropine, and ice, you know that methamphetamines also. The heart block occurred with poisoning with digoxin, beta blockers, and calcium channel blockers. Other than that, anion gap metabolic acid, that means normal pH of the blood 7.35 to 7.45. For the anion, if the pH is getting less, what are the most of the reason of the high anion gap metabolic acidosis? The methanonuria and diabetic ketoacidosis and salicylate and iron, especially getting higher metabolic rate and metabolic acidosis. We have to rule out and get a rough idea about the poisoning. Then we have to, at the same time, we manage the plan of decontamination. The activated charcoal is very well to giving according to the indications. Within 1 hour is the most appropriate time. The children 1 gram per kilogram maximum, they have to give 50 grams. Other than that, whole blood irrigations and enhanced eliminations, urinary alkalinization, those are the ways that most of the time in high pack, the ICU care, the real doing in Sri Lanka, most of the time we have to manage according to the symptomatic treatment. We have to get a rough idea about the antidote. The PCM poisoning, NAC, N-acetylcysteine, and opioid, the antidotes, the naloxone. And beta blockers, the glucagon as well as benzodiazepine, flumazenil. And iron dextroroxamide. We have to do, especially the iron activated charcoals is not working. That's not absorbed. What are the plans after the initial management of the child? If it is symptomatic, we have to discharge the child without having complications. So admitted to the ward if there is higher level of paracetamol toxic like, you have to continue NAC therapy. The admission to the ICU, it is worsening of and deteriorating the child, and managing in ICU setup is mandatory. I would like to get some examples in leading out. You have to day-to-day come across with paracetamol poisoning as well as the steroid poisoning. Just like look, the paracetamol poisoning, actually the onset of the action within 30 to 60 minutes. That means it's half of 4 to 6 hours. Protein binding is very low compared to the other drugs. It is rapidly absorbed in the small intestine. The peak plasma level, you have to know 30 to 30 minutes, because any pain relief within half an hour as well as 1.5 hour, like, as you know. And it is because the placenta. In breast milk, it appears after taking the paracetamol. We have to think for the paracetamol toxicity, what are the metabolism of the liver? There are 2 separate safe pathways. glucuronidation and sulfation. These are safe pathways. Normally, in physiologically, without having toxicity, high doses, the pathway smoothly appearing. Only 5 to 10% is toxic pathways. Cytochrome P450 pathway is a toxic pathway. N-acetyl benzoquinine and imine is a toxic substance that produce toxicity of the liver. What happened in overdose of the paracetamol? NAPQI is normally rapidly detoxify the glutathione. That means glutathione is this enzyme, then the protein in the liver is desensitized and decrease that excrete from the urine. If it is glutathione level is low, when toxicity is higher, the depletion of glutathione level because of the toxic pathway is getting higher and saturated, and safe pathways is saturated and toxic metabolites are higher in the liver, going ultimately liver failure and liver toxicity. The paracetamol dosage is toxic 150 per single injections, and multi-therapeutic dose is less than 48 hours is 150, and more than 48 hours 100 milligram per kilogram. What happened in overdose? Excess NAPQI is produced because of the saturated of safe pathways. Glutathione is depleted, and liver, that NAPQI is bind with liver protein, and ultimately hepatocellular necrosis occurs due to high amount of toxic metabolites. What is the mechanism of NAC? That means N-acetylcysteine for the antidote for methamphetamine. PCM poison, sorry. It is the producing glutathione and as well as directly detoxify the toxic metabolites and enhance the sulfation pathway. This is a very primitive as well as ultimately the child experience with major pathway of detoxifying pathway of the paracetamol, especially in children. And NAC is especially in a free radical scavenger, as well as this improve the hepatic microcirculations. Now I am just brief the pesticide poisoning. The pesticide is manufactured, that is Palibodhanasaka, they are produced at the target oriented. Actually, most of the neurotoxic disruption, especially organophosphate, carmate, insecticide, they are mainly affect to the nerve system of the neurojunctions and accumulate the acetylcholine level by affecting acetylcholine esterase level. Because of when acetylcholine level reduce, by the acetylcholine esterase, the organophosphate OP poisoning, they affect the acetylcholine esterase. So acetylcholine level in higher and getting higher in synapses ending of the nerves. Most of the people with cholinergic symptoms, cholinergic toxidrome, is presented with OP poisoning as the reason of high level of acetylcholine. OP is irreversibly bind to the acetylcholine esterase. So acetylcholine level is not regulate due to the OP poisoning, that cholinergic toxidrome is higher in OP poisoning. Other than that, aging is we have to treat as before 8 hours of OP poisoning is very good, because aging is that permanent bind of OP with acetylcholine esterase, a permanent bind, very difficult to treat with oxime in delayed presentation of OP poisoning. The pathophysiology is mainly due to muscarinic symptoms and nicotinic symptoms and CNS symptoms. Muscarinic symptoms just like cholinergic toxidrome symptoms, saliva, mysos, pinpoint pupil, diarrhea, urination, and all things for the leaking. The clinical syndromes, initially, the minute to hours, the life-threatening in cholinergic crisis due to the high level of acetylcholine. And intermediate syndrome, it occurs normally with misleading of the management. Initially, patient is get recovered after 1 to 2 days, getting suddenly got respiratory paralysis, and ultimately might be died because of due to intermediate syndrome, maybe due to the overstimulated the nerve endings due to high level of acetylcholine, the reason. Other than that, organophosphate induced delays neuropathy also in weeks to months. Patient with presented with some wrist drop, foot drops, as well as some neurological manifestations. The clinical diagnosis, the acetylcholine level is Sri Lanka very hard, very rare, only experimental levels only doing acetylcholine levels. And airway, that we have to maintain airway breathing and ABC, we have to maintain, and the contamination, dermal decontamination is mandatory while the patient admitted to the emergency department. As well as gastric decontamination, we have to perform presented with 1 to 2 hours life. Atropine is giving for the cover the indications for bronchiorrhea, that bronchospasm and bradycardia. The atropine might increase the muscarinic effect, as well as paradoxamine PAM. We can reactivate the acetylcholine esterase level. It is better to give early as possible, because other than that, aging is the mostly occur, but PAM is not working. it might go to the intermediate syndrome in due course for the delay of presentation and management. The supportive care, we have to give the optimize their all the parameters, circulation, respiratory parameters. We have to maintain new oxygen and IV drips as well as. This is a take-home message. The OP poisoning is the clinical diagnosis. We have to think about the toxicology. And other than that, early airway protection, respiratory paralysis and airway protection is mandatory and have to keep on eye. And in emergency situations, we have to always ready with intubations as well as supportive care. Atropine have to be continued until the dry of chest and reduce the crepitations of lungs. Other than that, we have to think about the intermediate syndrome. I would like to give some scenario. When I was working at the base hospital, Vatupitela, one patient came with severe toxicity. That means alcohol abuse patient with heart attack. That means anterior. The ECGs we got only percentage. He presented with chest pain. We were able to get the ECG at the moment, found that acute myocardial infarction. As Professor Carvin says that I want to go up with Snakebite also. Then we started treatment for heart attack. දැන් මේ මිනිස්සයා කියන දේ මොනවත් අහන්නෙත් නැහැ, කෑ ගහනවා, කපෝරි දෙනවා කියලා. අපි ECG ගත්තා, ගන්නකොට heart attack එකක් වාගේ ඒක manage කරගෙන යනවා. ගියා. ඊට පස්සේ streptokinase කියලා we have to give streptokinase for the anterior MI heart attack එකට අපි පටන් ගත්තා. පටන් අරගන්නකොට he bled, that means gum bleeding and all the other the difficulty not responding to that management. මනස හොඳටම බීලා හිටියේ. දැන් අර විතර තමයි යාවේ. ඊට පස්සේ තව ටික වෙලාවකින් ඇවිල්ලා ගෙදර කට්ටිය කිව්වා මේ කාමරය ඇතුලේ පොළගෙක් හිටියා. මේ පොළග කාලා වෙන්න ඇති කියලා. We observed that we are fine for actually. We found that there is a bite mark of the right leg. Then we have already given the streptokinase. What's the management plan, Professor Carvin? I want to know. What we did that we can't give AVS at the moment. He admitted to the ICU, but DIC was there because of the history. And ultimately we treated about 3 to 5 days in ICU, just God's sake they recovered. Can we give AVS for this patient? Yeah.
So I think it can be, so as I told in the presentation, you can remember Russell's Viper can cause direct cardiac toxicity.
Yeah.
So that venom envenomation can trigger acute myocardial infarction. So it may be that's the presentation of envenomation, not a cardiac kind of diabetes and hypertension related myocardial infarction. So
Yeah.
in the first instance, I think anti-venom could have been given, but the management becomes very complex when you have given
Yeah, actually
and
that
leading.
history is not known. It's
Yeah.
a very drunken.
I know.
Yeah, that very difficult that of that. ගෙදර මිනිස්සුන්ටත් එපා වෙලා ඉන්න මිනිස්සෙක්. ගෙදර මිනිස්සු ඇවිල්ලා වටේ ඉන්න කට්ටියක් තමයි අරගෙන ආවේ. දාලා වෙලා මරණක් කමන්නේ වාගේ. ඊට පස්සේ කවුරුහරි නැන්දාගේ දුවේ දුවට ඇවිල්ලා තමයි කිව්වේ කාමරය ඇතුලේ මේ ප්‍රසස් සයික එකකින් මරුවා වෙනාවේ ප්‍රසස් සයික. The case report also.
Yeah. So that will be a complex management.
Yeah.
First of all, you have to admit the patient to ICU and then give supportive treatment. And once the bleeding is controlled, I think did you give antivenom to that patient?
No.
Okay.
Because of the bleeding is there.
Yeah.
Very difficult to give that according to the we conduct the poison center and experts at that moment in 2014. Thank you, Raj. Okay, thank you very much for my brief presentation.